Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before I get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speaker. Joining us today, we have Dr. Naomi Patel. Dr. Patel is a rheumatologist in the Division of Rheumatology, Allergy, and Immunology at Mass General. She sees people with a variety of types of arthritis and other rheumatic diseases. Her research interests involve quantifying and assessing side effects of steroid medications in rheumatic diseases, as well as studying the clinical outcomes of patients with rheumatic disease and COVID-19 infection. She enjoys partnering with patients in their care, as well as teaching medical students, residents, and fellows. She joins us today to give a talk on hand arthritis. So please join me in welcoming Dr. Patel.
Thank you so much. Hello to everyone, and thank you for having me today. I will go ahead and share my screen to get started. Today, we'll be discussing hand arthritis and how to primarily minimize pain and maximize function. As an overview of the talk, we'll have several sections. First is an overview of different types of arthritis. Then we'll go into treatment involving both medications as well as non-pharmacologic or non-medication approaches, primarily to manage osteoarthritis, which will be the bulk of this talk. Arthritis is a leading cause of disability in the US. There are over 50 million adults and 300,000 children actually who have some type of arthritis. It's more frequent, particularly osteoarthritis with aging, although again, many children have certain types of inflammatory and autoimmune arthritides as well. There's a whole variety of different types, many of which people are familiar with, osteoarthritis being a primary example. Inflammatory arthritis, there's a whole bunch of different types in this category. Crystalline, so some people may be familiar with gout or pseudo-gout. There's infectious forms of arthritis, such as viral, bacterial, or otherwise, and other types as well. Osteoarthritis is the most common type of arthritis, and that's what this talk will primarily focus on. The age and sex-specific incidence rates of arthritis are shown here in terms of around 40-year-old at the lowest end and then 85 years old at the upper end. The knee is by far the most commonly affected joint, followed by the hand and hip, which have similar prevalence, with the hand starting even earlier in age than the hip. Different sites can be affected. So as mentioned, the knees, hip, and hands are definitely among the more common sites. The spine and shoulders are also very common, as are certain areas of the foot, including the big toe as well. And within the hands, we'll get into further details in terms of specific joints and other areas that can be affected. In terms of signs and symptoms of hand arthritis, pain and stiffness can be some of the earliest manifestations. The pain and stiffness both can tend to occur more so in the morning after waking or after prolonged periods of inactivity. And then the pain also is generally worse with joint use in osteoarthritis. So in terms of the knees or hips, this may be with walking or physical activity. And with the hands, this may be with things like doing things around the house, gardening, lifting things, typing, any kinds of activity with your hands. Joint tenderness, so this is more of a physical exam finding when someone pushes on the different areas that are affected. Limitation of motion, sometimes you may not have full flexion or extension abilities of the joints. Bony enlargement can also be seen. And so you can see in the photo here, there's bony enlargement, and we'll go over some of the anatomy of the hands as well. Joint deformity in some cases, this is often a fear that patients have when they come see me, is what will my hands look like 5, 10, 15, 20 years from now? And less commonly in osteoarthritis is soft tissue swelling and inflammation, though this is certainly a prominent feature of other types of arthritis, such as rheumatoid arthritis, gout, and others. In terms of the anatomy of the hands, I'll call your attention to several areas of joints, which are maybe a little bit more difficult to point out virtually than if we were all together in the same room. But the first we call the DIPs, or the distal interphalangeal joints. And these, if you look at your hands, are the joints closest to the fingernails. The next ones down are the proximal interphalangeal joints, or we call them the PIPs. And these are in the middle of the fingers. And then there are the MCPs, which connect the fingers to the hand, and those are less commonly affected in osteoarthritis, so won't be a focus here. And then the next one here is the CMC, which is down in between the wrist and where it meets the thumb. That's only in that first finger, and that's a very commonly affected area in osteoarthritis in particular. In terms of facts and figures about osteoarthritis, there's a whole ton of different bones in the hands and wrists, many of which come together to form many small joints, so more so even than what you just see by looking at your hand. And in terms of overall prevalence among the entire adult population, more commonly women rather than men will have symptomatic hand osteoarthritis, although as you saw in the prior slide, these prevalence rates vary significantly depending on the age. And if you look at just the first CMC joint, which is pointed out on the previous slide, by the age of 70 to 80, the prevalence rises to actually almost 70%. So very, very common. Not necessarily a normal factor of aging, but very common and something we see regularly. And the number of people affected by arthritis is expected to continue to increase, primarily given the aging of the population. We'll review different types of arthritis and how to make the diagnosis prior to jumping into treatment. In terms of types of arthritis, the osteoarthritis we mentioned, it sometimes is referred to as degenerative arthritis, although we're increasingly getting data that it's not just a degenerative condition. There's also erosive forms of osteoarthritis, which is less common, but you can have chronic damage in this condition, similar to what we see in things like rheumatoid arthritis. In terms of the category of inflammatory arthritis, rheumatoid arthritis is one of the more common forms that we treat. There's also crystalline forms such as gout and pseudo-gout, which are diagnosed in different ways, sometimes by actually putting a needle into the joint and drawing out fluid to evaluate for crystals, and sometimes by non-invasive methods such as ultrasound or other forms of imaging that can actually look and sometimes diagnose these as well. There's infectious forms of arthritis. So some viral conditions are associated with inflammatory arthritis particularly. And in some cases, there can be bacterial infections, especially when only one joint is affected. And there's other miscellaneous causes even besides these two that are beyond the scope of this talk, but can be considered in certain situations. In terms of the diagnosis of the specific type and thinking through all of these different possibilities, the primary thing that we really use is the patient's history, the most important component of all of this. And what we really look for is pain that's worse with joint use. So that's much more common in osteoarthritis. Compared to in inflammatory arthritis, people actually generally say that the pain improves with activity. So once they loosen up and get going, they actually feel better. Morning stiffness in osteoarthritis is common, is frequently present for less than 30 minutes. As opposed to in inflammatory arthritis, generally more than an hour or so. Sometimes people even take multiple hours to really loosen up and get going throughout the day. And if you ask about history of redness or swelling, that's relatively uncommon in osteoarthritis. So if joints are really red, really swollen, that raises concern for an alternative etiology. However, that needs to be distinguished from growth of the bone, which can be difficult to distinguish if you're not used to evaluating these joints. The physical exam is another big component of the diagnosis. So what we look for, again, the bony growth versus the soft tissue swelling. And at first glance, to some people, these may look similar, but once you've examined enough hands, and we'll go through some photos here in the context of this talk, you can start to see the difference and how they're actually distinguishable. The next thing is the distribution of joint involvement. So osteoarthritis much more commonly affects the DIPs. Again, those are the knuckles closest to your fingernails, and the PIPs. Those are the ones in the middle of your finger. As opposed to something like rheumatoid arthritis generally affects the biggest knuckles. So the ones that connect the hands to the fingers, and we call those the MCPs. And we also want to rule out other diagnoses. So sometimes you can see things on physical exam, say, that suggest something like gout or an alternative etiology that would require different, more targeted treatment. In terms of hand osteoarthritis, we have terms for the bony growth of certain joints. So the Heberden's nodes are the ones that affect the DIPs. Again, those are the joints closest to the fingernails. And Bouchard's nodes are the joints affecting the PIPs, so bony growth in that area. And you can see that on this diagram. There's no terminology for the CMC joint, and generally you don't see the bony growth there as much. But what you can see is what we call squaring of the CMC joint. So instead of having a nice smooth curvature, you can see more of a square-like shape. And some of you may notice that on yourselves as well if you're participating here and happen to have hand osteoarthritis. So here are a couple photos, and you can actually see the squaring of the CMC here on this patient. I'm not sure if my pointer comes through via Zoom, but you can see here the squaring. And then you can see there's a lot of bony growth of these PIPs and less so the DIPs of this patient, but this PIP level. Whereas it's not so much red and swollen in terms of soft tissue, but you can see that these bones are all quite enlarged. You can compare that to something like rheumatoid arthritis, where this is a different condition. This more predominantly affects the MCPs, so these large knuckles that connect the hand. There's a lot of soft tissue swelling, which you can compare going back to the prior slide with this being more bony involvement and this being more soft tissue involvement. And there's also some ulnar deviation and subluxation. So you can see that even aside from the swelling, this level of joints, there's some slanting of the fingers and a little bit of indentation or subluxation there that's not normal. Here's some other examples of rheumatoid arthritis with swelling across these PIP joints in the middle of the hands. Rheumatoid arthritis less frequently affects the DIPs, so these knuckles toward the nails actually appear relatively normal in this patient. And here's another more chronic example of rheumatoid arthritis, also primarily affecting the MCPs, so the biggest knuckles, with ulnar deviation, meaning the fingers are slanted outwards, and subluxation, so some indentation and abnormal contour here. Another condition which I mentioned that can commonly affect the hands is gout. And so gout is a disease of uric acid crystals, and not always do you see tophi. These are these white deposits that you can see sometimes over the knuckles, sometimes different areas. They have a kind of white, creamy, or sometimes calcified discharge. Sometimes you can even squeeze it out through the skin or see it right under the skin, like in these examples. And this is, again, a different disease that requires different treatment targeted at uric acid. So you really want to make sure you have the right diagnosis prior to proceeding with treatment. The diagnosis of osteoarthritis is often made clinically, and so often all you need is the history and the physical exam if everything seems consistent with osteoarthritis. It's often not necessary to get things like x-rays, or certainly not to do any form of a joint tap or synovial fluid analysis where you put a needle into the joint if osteoarthritis is suspected. If you're looking at something like rheumatoid arthritis, or you're concerned for gout or an alternative cause, then in some cases these are pursued in order to make sure, number one, you're not missing anything else, and number two, sometimes to monitor the progression by looking at x-rays over the course of time, so over the course of years. Here is an example of a normal hand x-ray. And so here you see it's a hand with, these are the MCPs. This next level is the PIPs and the DIPs. And you can see a nice smooth contour of the bone. You can see nice clean joint spaces. So space between where the two bones come together, and overall relatively normal appearing. If you contrast that to hands that are affected by osteoarthritis, you'll notice a few things. So number one, this hand, particularly at the DIPs up here, You can see that there's a lot of loss of the normal bone space. There's bony overgrowth. So you can see, compared to what you see on the actual hands, you can see that there's extra bone here. So you actually see that bony growth. And then down here at the CMC, where this thumb meets the hand, you can also see that this joint space is narrowed more so than it was on the normal hand x-ray. And this is just a slightly zoomed in version of the x-ray on the slide before. But again, you see some degree of almost bone on bone here, where there's really loss of cartilage and normal joint space. And then there's a suggestion of possible erosions. If you look, say, in the middle of this joint space, instead of seeing a nice smooth contour like you do here of the bone, you see kind of some damage and jagged edge to the bone, which may be suggestive of some degree of erosions or actual damage in that area. So if osteoarthritis is suspected, we'll go into some discussion about medications to treat it. And again, the rest of this talk will focus primarily on osteoarthritis. Some things are applicable to other types of arthritis as well, but we won't go into the detail of things like rheumatoid arthritis or gout treatment here during this talk. The principles of treatment are several-fold. So number one, there's no medication to reverse the underlying cause in osteoarthritis. This can be distressing to some people because it can be difficult to predict the rate of change over time, to predict what someone's hands or other body parts may look like years down the line. But the good news is we have a lot of different options to target different aspects of care. Ultimately, what that comes down to is the goals of reducing pain and improving function or maintaining function in some people who may not have any concerns in that domain yet. And so patients should be provided with education on self-management and treatment options, and they should always take into consideration the severity of arthritis as well as other health conditions as well. Sometimes a multidisciplinary approach is needed, especially with allied fields such as physical or occupational therapy or others, sometimes orthopedic specialists, with both non-pharmacologic and pharmacologic options. Surgery is very rarely needed. In terms of different medication options, I'll guide some of this discussion based on the 2019 American College of Rheumatology treatment guidelines for osteoarthritis. And this encompassed both hand, knee, and hip osteoarthritis. Some of these have overlapping treatment modalities, but here we'll be primarily discussing the hands. And again, many of these apply to other body parts, and some even apply to other types of arthritis as well. So we'll go through these one by one, but you can see here this darker green box represents treatments that are more strongly recommended, and the lighter green box recommends treatments that are conditionally recommended. And we'll touch briefly on, but not really go into detail on things that are not recommended as well. In terms of medications, first, always talk to your doctor before taking any medication, even over-the-counter ones such as Tylenol or acetaminophen or ibuprofen or anti-inflammatories, because these can have substantial side effects, again, even being over the counter. So always discuss these treatments with your doctor, but these are certain ones to consider. So different medications. First, oral non-steroidal anti-inflammatory drugs. I'll call these NSAIDs for short. And these are things like ibuprofen, diclofenac, naproxen, and many others. Topical treatments when possible. We'll go into detail on some of these, both topical anti-inflammatories as well as topical capsaicin. Oral acetaminophen, which Tylenol is one brand name, or duloxetine can be used also for pain control. Tramadol, although this is in the opioid category of medications and also has similar substantial risks as well, so need to balance those. Sometimes glucocorticoid injections, so steroid injections, can be used for painful joints. We generally can't do these for all joints because there's limitations both in the practicality as well as the risks. But sometimes if there's several key joints affected, or particularly if there's one key joint affected, these can be very effective treatment options and come with minimal to often no systemic side effects. To dive into detail on a few of these, so first, to review oral NSAIDs. So again, these are non-steroidal anti-inflammatory drugs. There's ibuprofen, there's naproxen, celecoxib, meloxicam, diclofenac, indomethacin. There's a whole host of different ones. And many of them have been studied in different trials, and all of them have been shown to be better than placebo, so better than no therapy in osteoarthritis. And most of all the different options are pretty similarly effective. So I generally tell people that you could essentially reach into a bag and pick any out blindly and have similar efficacy, and that individuals sometimes tend to respond better to one medication than another. And sometimes it takes trying a few different options in order to sort that out. I will say again, while many of these, not all, but many are over the counter, there are substantial risks to NSAIDs, and they should be avoided in certain people with certain either medical issues or medications. Blood thinners being a key one. Also, if you have any history of peptic ulcer disease, they can cause stomach irritation. If you've had gastric bypass surgery, if you have low platelets, that can predispose you to bleeding, or inflammatory bowel disease with inflammation of the bowels. If you have bad kidney disease or heart disease, they can pose slight risks there as well. So again, many reasons to talk to your doctor before using these, even if it's something that is over the counter, but can be very effective, even though osteoarthritis is not primarily thought to be an inflammatory disease, are very effective in pain control as well. Next, in terms of treatment, acetaminophen. So one of the brand names is Tylenol, that most people are familiar with. This comes in various doses. It comes in various capsules and tabs. It comes in extended release. There's Tylenol arthritis that you may see marketed at certain stores. And so generally the very, very, very maximum that you'd want to consider is around 4,000 milligrams a day of this medication. And in many cases, if you have any degree of liver disease or certain other medical issues, you may want to consider even a lower maximum dose each day, particularly if you have liver disease. This is not quite as effective for pain control as the anti-inflammatories. And so as such, it's not as highly recommended, but certainly is tolerated very well by many people and can work well as adjunctive therapy. So some people ask about immunosuppressive medications, and we generally do not treat osteoarthritis with the conventional immunosuppressive therapy that we use, or especially not the biologics. And this is tough because you've probably seen these ads on TV saying, talk to your doctor if you have arthritis about this medication, this injection. And so we do see people coming in asking about these types of treatments. But in general, these are all therapies that are either for rheumatoid arthritis or psoriatic arthritis or other very specific forms of arthritis, but not for osteoarthritis. And so that's a conversation also that I frequently have, because the pathways involved in these different diseases are very different from one another. Another thing to touch on, something that's not recommended, is opioids are generally not recommended for multiple reasons. The first of which is that they're generally not effective in osteoarthritis, certainly not with the stiffness and function. And even the pain intensity and scores in studies looking at longitudinal pain scores over time have not been shown to be better in those who received opioids compared to those who actually didn't. And so while some people may anecdotally feel that they do help temporarily with certain aspects of pain, both these studies as well as the risks really make them not recommended for treatment, either in the short or the long term. The risks, I think many people are somewhat familiar, but just to review some, certainly dependence, addiction, and misuse are risks of opioids. There's respiratory depression. We often recommend that if someone is on opioids, that it's given along with a reversal agent called naloxone. Falls, and then even in certain populations, cardiovascular risk, and they're associated with an increased risk of death in multiple populations as well. So many reasons to be concerned and try to avoid these and really focus on these other modalities of pain and functional control. Going into some of the non-pharmacologic approaches. In terms of the ACR, so that's American College of Rheumatology guidelines, going back to these, again, this was the 2019 updated version, encompassing the hand, the knee, and the hip. We'll go over some treatments that are strongly recommended. Again, that's the darker green box, as well as conditionally recommended. That's the lighter green box. In terms of, we'll go through some of these one by one. Some are slightly more applicable to the knee and the hip. Although again, as I mentioned, we're also gaining new understanding of things like weight loss and exercise and how these can affect more so the hands and other components that we were aware of previously, and not just the weight-bearing joints. Weight loss can be helpful in osteoarthritis. And so Osteoarthritis can be exacerbated by obesity or even different degrees of being overweight. And there's different ways in which this happens. There's reduced physical stress and load on the joints that can impact pain. This is most applicable for the weight-bearing joints like the knees and the hips that are bearing the brunt of weight bearing for the body. And so it's slightly less applicable to the hands. However, there's data showing that obesity and diabetes and other metabolic factors are risk factors for hand osteoarthritis. And it's not as well understood if weight loss will impact improvement in the hands, hence why it wasn't necessarily a key component of the ACR recommendations. But again, we're getting increasing understanding that it's not just the physical weight in the body, but that obesity actually contributes to pro-inflammatory cytokines and mediators that can be released in the blood and affect the hands even aside from the physical load of weight. When we do recommend weight loss, especially for those weight-bearing joints, the goal reduction is generally around 7 to 10% of the body weight loss. And this is a substantial amount. If you calculate that for, 150, 200, 300 pound person, it's a lot of weight. And so there's different ways to go about that. And ultimately for the purpose of arthritis, it doesn't necessarily matter how that occurs. There's exercise, dietary change, obviously much easier said than done. It requires a lot of regular activity and input. There are medications, obviously, that would be used carefully in conjunction with a doctor. There's also surgery. So we've seen people have excellent outcomes from certain bariatric surgeries as well. But all of these are complex decisions that would require a multidisciplinary approach. And again, weight loss can actually improve pain in rheumatoid arthritis as well. While rheumatoid arthritis is not primarily a mechanical disease, the primary insult there is inflammation. We see that there's such a tight link between weight, obesity, and inflammation that there's data that weight loss and exercise can help with rheumatoid arthritis too. And so here's some of that data. And this was actually in a study of patients with rheumatoid arthritis. And so this was two groups of patients. One was randomized to a diet and weight loss group. That's the green arm on the graph here. And then the other was a control group. So they were going about their normal daily lives in terms of physical activity and diet. And that's the blue group. And the RAPID-3 score is a disease activity score. And so lower score means lower disease activity, which is better, which is what we want. And you can see over this 12-week period on the graph, the diet group, again, this green arm, had a substantial decline in RAPID-3 scores compared to the control group. That was over 12 weeks, and that was with them losing 9.5 kilograms in the diet group versus 0.5 kilograms in the control group. Again, 9.5 kilograms is a substantial amount of weight to lose. And so this was just one study, but did demonstrate and I think support the concept of weight loss contributing both to reductions in inflammation as well as to improved pain in a variety of conditions. Physical activity next can help. Again, there's increasing data that osteoarthritis is not just a degenerative condition. Even several years ago, when I talked to patients about osteoarthritis, I said this is degenerative and this is a wear and tear disease. And increasingly over the years, we're finding more robust evidence that there's some degree of microinflammation in osteoarthritis and that it's not just degenerative. And we're learning more and more about both why it occurs and how to treat it in this regard. For the physical activity, there is more robust evidence for this helping in the knee and the hip as compared to the hands. At the same time, there's so many benefits of physical activity that I recommend it for all patients. People often wonder if physical activity will make osteoarthritis worse. And generally the answer is no, that there's always benefits to activity. The slight exception being that some people find that certain degrees of activity hurt. And in that case, it's of course important to listen to your body and to not necessarily push through pain, or to see either a formal physical therapist or someone else to help work through those issues and see either if there's something else contributing to your pain that needs to be addressed, or to just do very slow graded exercises in order to try and avoid that pain. For knees and hips, this exercise can consist of walking, strengthening, neuromuscular training, aquatic exercise. Again, there's a whole variety of different activities that can be done. For the hands, we'll get into a couple of detailed things that can be done shortly. And some studies have shown that this is more effective when supervised, for example, by a physical therapist or in a class, as opposed to what we do sometimes for patients is give them handouts of exercises that can be done at home. And this is due to a variety of factors. One is it can be difficult to have the right form when you're doing something on your own, especially if you don't have someone to watch how you're doing it or a mirror. And otherwise, it's the persistence too, that it's more helpful sometimes to have either a class or a physical therapist just to ensure that you're able to keep up with that regimen, as opposed to relying on remembering to do it on your own, potentially at home. In terms of treatments, in terms of the non-pharmacologic treatments, there's occupational therapy, and we have excellent occupational therapists who we work with at MGH. I'm sure many institutions have phenomenal occupational therapists who can help with a whole variety of things beyond exercises. Some of the occupational therapists have abilities to make specialized splints, individualized assistive devices, and then some have more standard things, which we'll get into in a few slides, in terms of helping you do day-to-day activities that may be a bit difficult depending on the degree of stiffness or pain or bony enlargement, or sometimes deformity that you may have in your hands. The point of the exercises is several-fold. So to improve muscle strength, sometimes the strength can decline for several reasons, one of which is if you're not using your hands normally or in the ways that you used to. To improve range of motion, which is something we want to maintain and not have ideally decrease over time. And then to reduce function, which can require some specialized attention for different, again, daily household or other tasks that people can find difficult. And so here's one study that evaluated the effectiveness of home-based hand exercises in women with hand OA. And you can see here on the diagram, there's some different exercises that these were in the examples of exercises that were handed out to patients in terms of stretching, strengthening, gripping, rolling, and focusing on strength of individual fingers. This study showed, it was again a randomized trial of hand osteoarthritis information. So this was group 1 versus hand osteoarthritis information with these specialized home-based hand exercises, which was the second group. And this study looked at their primary outcome of an activity performance score, with 0 being the worst and 10 being the best score. And the exercise group had an improved average of 1.4 points compared to the information-only group. And so they had improved grip strength, which many people complain of in terms of difficulty with opening bottles, opening doorknobs, other things that require both the strength and the grip. They actually had improved fatigue, they had improved joint pain, and improved overall function. So can be somewhat effective. And again, a lot of these are used in conjunction with other modalities of both pharmacologic and non-pharmacologic treatment. So this was some of the informational handout that was provided to patients in terms of suggestions for how to use the hands and how to go about these activities. So one was to use both hands. The example being if you're carrying something heavy like a frying pan, you want to use both hands just to minimize the strain on one hand. And some of these things seem fairly obvious, but we all get into the routine and habit of doing our daily activities and sometimes don't necessarily think about focusing as much on these potentially joint protective maneuvers. Transferring weight from the smaller to the larger joints. So instead of carrying something, say, on the fingers, you can put it on your shoulder or elsewhere in order to not have too much strain on the hands. Using lighter equipment. So sometimes it means that, maybe different things would be purchased, or if there's someone at home to help to avoid having something so heavy and being able to lift something lighter instead. Using alternative hand grips. So we can go, I think in a couple slides, there's some images of assistive devices in terms of gripping, and then balancing activity and rest. Again, physical activity is helpful and certainly recommended, But at the same time, you want to listen to your body. If you need to rest, if something's hurting, listen to that and balance that physical activity versus rest. Kinesiotaping is something that can also help. Some of you may have seen these types of tape you can generally buy in the drugstores like CVS or Walgreens. There's supportive tapes, and then this particular example is the thumb base, which is the CMC joint to improve grip and pinch strength, and then also to help support the joint and reduce any associated pain. So there's different areas that can be taped. Some people do their shoulders, elbows, knees, all different areas if you know how to apply it. The orthotics are very common, and we generally recommend these for thumb base OA. Again, that's the CMC joint. There's different types. So there's more firm ones, which you can see on the image on the right. You can see it's a hard plastic material. And sometimes we'll use the stiffer, more firm ones to decrease pain and actually wear through the night, because those can make it more difficult if you do something during the day that requires frequent use of your hands. Even at night, we're constantly moving and straining our hands when you roll over, when you curl up. And so even at night, these can help. Some people prefer the more flexible supports for daytime use. So that would be the one on the left. And these can generally be purchased also either at a drugstore or online in different materials as well. And there's also ring orthoses, which I don't have a photo of here to support individual digits, but it basically is a soft material like a ring. And sometimes you can put it on certain joints like the PIPs or the DIPs to help reduce the strain and support that individual joint if there's certain ones that are affected. Different adaptive devices that we'll go over. Button hooks. So many people complain of putting clothes on when they require using small buttons. Some people actually change their wardrobe such that things are easier to either zip up or pull over without using the buttons. But this is a small device that can help get the buttons through without needing to maneuver your hands through the very small holes. Sock aids, another thing that people commonly report having difficulty with to help pull the socks up. And this can also be particularly tough, not only with the hands, but if you have trouble leaning all the way over, whether due to back or shoulder pain or other areas that may be hurting or stiff, it can be difficult. Rubber thimble for things like turning pages of books, something to just get a little bit of friction and help turn pages can be helpful. Dyson material. So this is an excellent material. It's a very good grip material, and it has tons of different uses. So some people wrap their doorknobs in them just so they're not as slippery in terms of turning them. And some people also will just save some of this on the side to do things like opening jars or opening other things where you need a bit of extra grip. Cylindrical foam. So in terms of eating utensils, a lot of spoons, forks, and other utensils have really narrow areas to grip, and some people find it hard, whether or not there's any deformity, to grip that narrow of an object. And so there's these cylindrical foam devices that basically, are exactly as they appear, where they go over the fork or spoon and make it much easier to hold something much wider as opposed to something much more narrow. And then long handle sponges. So some people have difficulty in the shower or the bath with washing themselves, reaching around to certain areas. And so this is just something that can help you maybe reach places where you otherwise wouldn't be able to. And so a lot of these things, are just, they won't necessarily affect the underlying course of your osteoarthritis, but a lot of the daily tasks are things that people have a lot of difficulty with. And these are ways that can generally help to make them a bit easier. Some of these you can purchase on your own, of course, in the drugstore or online or elsewhere. And then some, if you see an occupational therapist or someone specialized in both assistive devices and exercises, they can help identify which of these may be most helpful for you as an individual. The next thing to touch on are paraffin wax baths that can help with osteoarthritis pain. These are purchased also either in a store or online, and they are a warm wax bath. And so what you do is you turn it on and heat it to a safe level. You dip both hands in and let the wax harden. pull them out, and you can let it go for as long as you want, generally half an hour or shorter or longer. And some people cover them in plastic to trap the heat in and then peel it off. And it can be very helpful for feeling soothing. The warmth can help people loosen up. It's a little bit labor intensive. You have to manage the wax. You have to keep it, of course, in a safe place. You have to purchase it on your own. I don't believe these are covered necessarily by insurance. They range in price from, $30 or so to even over $100 for more expensive ones. But some people really find a lot of benefit from them and use them regularly when it helps. Massage therapy, there's not too much data for. Of course, some people, anecdotally and subjectively say that massage helps, in which case, of course, I recommend they continue if that's something that does. Acupuncture, same thing, not too much data to support this, particularly for hand osteoarthritis. There are for other conditions. But again, certain individuals may achieve benefit from this. Certain types of soft tissue manipulation therapy to do at home that kind of go along with some of the exercises previously provided. And then sometimes ice packs can be used for acute inflammation. So sometimes in osteoarthritis, even though it's not necessarily a primarily inflammatory condition, sometimes people can have what they refer to as flares, where sometimes there is a bit of redness or a joint can get irritated, especially with the bony enlargement with strain or friction against anything. And in these cases, sometimes ice packs can be acutely helpful. And last, in terms of treatment options, when to consider surgery, some people ask about. So surgery is very rarely needed. There's structural abnormalities when other treatment options have not been affected is sometimes when we consider surgery, but it really depends on the degree of pain and the degree of impaired function. The surgery generally will not help the function. Frequently, what's done is an arthrodesis, which is a joint fusion. Rarely an arthroplasty, joint replacement. It depends on the joint, but rarely done in the hands. For things like the knees and the hips, joint replacement is a more frequent option where it can certainly improve function. But in the hands, generally what's done, especially in the smaller hand joints, is a fusion. So you won't necessarily be getting any improved functional control, but what it can often help is pain. When people have either substantial pain or significant deformity and are interested, then in those cases, it's certainly helpful to talk to an orthopedic surgeon and to consider what options there may be in that unique situation. In the thumb base, so the CMC osteoarthritis, a trapeziectomy, so actually taking out part or all of one of the hand bones can be considered in certain circumstances as well. In terms of take-home points, osteoarthritis of the hands can be distinguished from other forms of arthritis, primarily by the history and physical exam. Again, often we do not need things like x-rays or blood tests or images or specialized tests or joint aspirations to distinguish this from things like rheumatoid arthritis, gout, and other conditions that we treat. And topical and oral medications can all be helpful for the treatment of osteoarthritis, again, with the goals of minimizing pain and sometimes reducing function as well, or improving function. And exercise and weight loss can be key components of the non-pharmacologic therapy in osteoarthritis, even more so for joints such as the knees and the hips, but also for the hands as well. And last, occupational therapy, orthotics, other adaptive devices, such as some of the ones that I had pictured earlier, can also all help to improve the functional status and pain in osteoarthritis. Thank you so much for having me, and I'm happy to take any questions.
Thank you so much, Patel, for a wonderful presentation. We are now at the end of the session.
Of course.
So if you have any questions for Dr. Patel, feel free to enter them in the chat. So we have a question regarding osteoarthritis and whether they run in families. If so, are there things to do to avoid the progression?
It's such a good question. There is some familial component to our osteoarthritis, not as much as in certain other conditions. And there's certainly no one gene that's passed on, but especially if you have parents, and particularly even for women, there may be slightly more data for their mother being affected. But there's really not too much to prevent it, which is difficult. Some people who have a lot of strain on the joints, a lot of sports, a lot of use of their hands over the years, in some cases that's thought to maybe contribute to some degeneration, but we don't recommend that people limit any activities that they would otherwise be doing. And there's really no medication or anything else to prevent it. So we generally recommend that you live your life, and we're here to help address any pain or functional impairments if anything develops at any point.
Thank you. Are there any arthritis types that are linked to inflammatory bowel disease?
Great question. Yes, inflammatory bowel disease can be associated with the category of arthritides called spondyloarthropathies. So those are the category of diseases that relate to ankylosing spondylitis, psoriatic arthritis, IBD-associated arthritis, or reactive arthritis. And so, yes, those can affect the low back as well as other peripheral joints and be associated with IBD. And those are forms of inflammatory arthritis. So certainly we see people with IBD who are being evaluated for those types.
Thank you. Carbohydrates such as bread negatively affecting osteoarthritis. Is that a fact or a myth?
It's interesting. I'm not aware of any data that carbs have any impact on osteoarthritis, pain, or function. So I'm not aware of anything in that regard. It's certainly not something that's generally accepted to be a risk factor. There is some, data for gluten being a slightly pro-inflammatory component of the diet in certain diseases, particularly more inflammatory arthritides, but it's also just an area we don't know enough about as of now. And I wouldn't consider it to be a risk factor for osteoarthritis.
Thank you. Is surgery typically done when there are nodes growing on the joint?
The surgery is generally done in situations where there's substantial pain or impairment in function. And so in terms of nodes, I'm not sure if you want to clarify in the chat if the question is referring to bony overgrowth or any soft tissue nodules. If there's bony growth, we wouldn't necessarily do surgery just for the growth. Again, it's often really if it's bothersome, because generally these are not things that are dangerous. It's more a matter of how bothersome it is. If there's nodes in terms of nodules or soft tissue lesions, that would make me suspect potentially something else. And then I'd want to dive a little bit further into making sure you're not missing an alternative diagnosis.
Thank you. Can you discuss a little bit about what's the difference between erosive and degenerative?
Great question. Yeah, degenerative means they're both fairly broad terms, but degenerative often refers to degeneration of the cartilage. So all of our joints are lined with cartilage, or certain joints are lined with cartilage. And when that breaks down, that's generally what people refer to when they mean degenerative arthritis. Whereas erosions are actually erosions in the bone. And so those can form from a variety of things, inflammation being the biggest factor. So in things like gout or rheumatoid arthritis, in things like osteoarthritis, you can get erosions as well, although they're different than others in appearance and in the location that they can appear.
Thank you. And going back to our previous question, our participant clarified that they are referring to soft tissue growth. So I don't know if you have anything to add to that.
Oh, I see. Yeah, if there's soft tissue growth on the fingers, there's a whole variety of conditions that can cause soft tissue nodules throughout the hands. And there's a whole long list. So that would depend on what the condition is. Anything ranging from infectious diseases to non-infectious to metabolic to inflammatory. And so in those cases, sometimes we'll involve our dermatology colleagues if it's not imminently apparent what the diagnosis is, and sometimes even do a biopsy of one of the lesions to first figure out what the diagnosis is. But I wouldn't necessarily jump to joint surgery without knowing exactly what you're treating.
Thank you. Can taking medications such as statins exacerbate osteoarthritis in the hands?
Not that I'm aware of. Not that I'm aware of.
And then we have a couple of questions that weren't part of today's talk, but want to see if you have any comments that thoughts you can share. Are you able to share more about trigger hand and finger?
Yeah, great question. Trigger finger is a condition where it's called stenosing flexor tenosynovitis is the more medical term, but it generally refers to when one finger gets locked in place. And sometimes people say, I have to use the other hand to pry it open. And that generally refers to the flexor tendon, which runs along the finger here. Often you can have an inflammatory nodule here when that happens and it gets stuck. I wish I could pull up a diagram to show maybe online in terms of the nodule getting stuck under the flexor tendon. But generally that can occur in either by itself or sometimes it does occur more frequently in people with other things like rheumatoid arthritis or other conditions. But many people just get trigger finger, and it's generally something that's much more of an issue of the tendons. Sometimes we'll do things like a steroid injection over that area if it's really inflamed. Some people can use splints to help protect the finger and settle down that lesion since friction can aggravate it. But great question. Different condition that we can see in combination with osteoarthritis, rheumatoid arthritis, and others, whether related or unrelated.
Thank you. You briefly touched upon gout. Can you share what the differences are between gout and pseudo-gout?
Yes. So gout is a condition caused by uric acid crystals, and it can affect the joints. The most common one is the big toe, and we call that podagra when it affects that area. And we need to treat it by lowering the uric acid in the blood. So you treat with anti-inflammatories, but ultimately lowering the uric acid in the blood is how to prevent gout. Pseudo-gout is a disease caused by calcium pyrophosphate crystals. So they're also crystals, but they're completely different composition of crystals than in gout. It has nothing to do with uric acid. And so in that condition also, it can similarly affect the joints, not as commonly the big toe, but certainly commonly the wrist, the knees, the hip, the shoulders, and other areas. And in that case, we treat the acute inflammation, and it's a little bit more difficult to treat because it doesn't have anything to do with uric acid, and the crystals can be a little bit harder to prevent. But that's the primary difference, different types of crystals.
Thank you. Can you help us explain what subluxation is?
Yeah, subluxation is a type of joint instability where there's a either incomplete or partial dislocation of the joint. And so if you have an example, so say the fingers that are, straight here, subluxation would be commonly at the MCPs in something like rheumatoid arthritis, where you have a partial, it's generally a downward dislocation. Other areas can be affected as well. And it's not a common feature of osteoarthritis. I believe it was in one of the earlier photos I shared of patients' hands with rheumatoid arthritis.
Thank you. Can you expand on what a other diagnosis might be and what you might investigate further if it could possibly not be osteoarthritis, particularly in the DIP joints?
Yeah, definitely. So in terms of the DIP joints, rheumatoid arthritis less commonly affects those areas. And so the first thing really goes back to the history and physical exam. If you're looking at mostly bony growth without soft tissue swelling, then that still would more suggest osteoarthritis. But if you're looking at soft tissue swelling, redness, warmth of those areas, then psoriatic arthritis is another common condition, not common, but common in the realm of things we treat that can affect the DIPs. And it can occur in the absence of skin psoriasis. It can occur in conjunction with psoriasis of the skin, but you don't need to have that. Other factors that support that are what we call dactylitis or sausage digits. If you have a finger or toe swell up like a sausage, hitting of the nails, family history of either psoriasis or psoriatic arthritis. And other conditions as well, gout or pseudo gout, both crystalline arthritides can also affect those areas. So they can be tough to distinguish. The osteoarthritis and psoriatic arthritis can be tough to distinguish if it's not imminently apparent. Sometimes things like an MRI or an ultrasound can better look to see if there's any swelling in the joint, any erosions in certain areas that would suggest one or another. or any inflammation of the tendons as well, which can also suggest psoriatic arthritis if present.
Thank you. This is all extremely helpful. While we wait to see if there are any further questions, are there any final thoughts you'd like to share with the audience?
I appreciate you all having me. And I think, osteoarthritis is something incredibly common, as you saw in some of the prevalence rates earlier in the presentation. It's not normal. Many things that are common are not necessarily normal, but very commonly experienced. And ultimately, I think it really is a matter of determining how uncomfortable it is. For some people, it's not something that's bothersome at all. And again, it's generally not something that's dangerous. And determining what to do in a really personalized plan. There's really no one size fits all treatment approach, and all of it is individualized depending on, number one, what someone's experiencing from the osteoarthritis standpoint, and number two, what other medical issues and other priorities they may have.
Thank you so much, Dr. Patel. And everyone who took the time to join us today, thank you so much. As I had mentioned, today's program is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you for having me.